welcome to my channel Nursing Gyan. As we were discussing related to the congenital heart disease series, last class we have explained related to the atrial septal defect. Today under same acyanotic condition, that too under increased pulmonary blood flow, we will discuss related to the ventricular septal defect. Well, starting with ventricular septal defect, about description. Before description, just I will label the structure of the heart. This is superior vena cava, this is inferior vena cava, right atrium, left atrium, right ventricle, left ventricle, pulmonary opening, aortic opening. This is the ascending aorta, and these are the branches of pulmonary artery, and these are branches of pulmonary vein, and this is descending aorta. Okay, let's move towards the ventricular septal defect. As discussed earlier, atriums are the upper chambers and ventricular are lower chamber. Upper chambers are particularly for pumping the blood and ventriculars for receiving the blood. As you know, compared to atrium, ventricular chamber has larger space or larger structure. So, ventricular septal defect is nothing but a defect present in between the septum of two ventricles. Okay, a defect or a hole or an abnormality which is present in between right ventricle and left ventricle of that particular septum. So that is nothing but ventricular septal defect. Going towards the types, actually in ventricular septal defect there are two types. It is based upon the width of the septum. If you see at the proximal edge, the width is very narrow or it is too thin. If you go at the distal edge of the particular septum, it is very thick. So based on that particular width of the septum, it is divided into two. Okay, one, this is two. If you see, first one is membranous defect. Membranous defect. And second one is muscular defect. Muscular defect. If you see membranous defect, the septum is very thin. It is very thin. And if you see at around the distal edge of the septum, it is very thick. So if at all, if there is a defect in this particular region, that is called as muscular, because septum is very muscular here. And if you see at the upper edge or proximal edge, it becomes very thin. If at all the anatomically defect is present over there, it is called as a membranous defect. So this is related to the types of ventricular septal defect. Moving towards the hemodynamics. I will explain hemodynamics of ventricular septal defect in two parts. One is structural hemodynamic, like what are changes takes place in the structure of the heart. One is in the flow chart. Okay, first moving towards the structural hemodynamics. As you know, the deoxygenated blood from superior vena cava and inferior vena cava, it will come to the right atrium of the heart. From right atrium of the heart, blood should go to the right ventricle. From right ventricle, it will go through pulmonary opening to left and right pulmonary artery respectively. After that, through lung, it will become oxygenated and come to the pulmonary vein. From pulmonary vein, blood will come to the left atrium. From left atrium, blood will go to the left ventricle. But when there is a defect over here, as you know, the left-sided heart is pressurized or it has a high resistance. Usually blood from the left ventricle will move towards the right ventricle. That is, high pressure left ventricle will allow the blood to go to the low pressure right ventricle. So this is where left to right shunting occurs. And if you see, right ventricle has blood from right atrium also, and right ventricle has blood from left ventricle also. So that's what the blood within the right ventricle will increase, and it puts pressure over the pulmonary opening. Okay, if there is a pulmonary opening pressure, again there is increased pressure in the pulmonary arteries, and that lead to increased pulmonary blood flow. That's why ventricular septal defect will also come under increased pulmonary blood flow condition. Okay, now we'll see related to the flow chart. First one is the blood from superior vena cava plus inferior vena cava, it will go to the right atrium. So I am indicating, or I am writing this with blue because this is deoxygenated blood. And from right atrium, blood will go to the right ventricle. From right ventricle, blood will go to the pulmonary opening. Through pulmonary opening, from right pulmonary artery plus left pulmonary artery, it will go to the lungs. It may be right or left lung. Okay, once the blood is oxygenated, the blood from pulmonary opening will come to the left atrium. From left atrium, it will go to the left ventricle. From left ventricle, there are two mechanisms which occurs are. First one is that usually normally it should go to the left ventricle, then left ventricle it should go to the aorta. From aorta it should go to the upper part of the aorta and descending aorta. Whereas because of this particular defect, some of the blood from left ventricle it will go to the right ventricle. Right ventricle has its own blood plus the blood sent from the left ventricle. That's what there is an increased pressure in right ventricle, and this particular increased pressure in the right ventricle increase the pressure towards the pulmonary opening, and if the pulmonary opening has pressure, automatically right plus left pulmonary artery pressure increases, where it will lead to the increased pulmonary blood flow towards the lungs. So this is the flow chart of hemodynamics in relation to the ventricular septal defect, where at the last there is a increased pulmonary blood flow. Next we will see related to the clinical feature. As we have seen in the atrial septal defect, same here also the first condition is asymptomatic. Whenever if the width is too small, then baby will not have any problem because of the adequate blood supply. If there is adequate blood supply, there is no need to worry because the supply is proper, and that's why this come under acyanotic condition also. But if at all there is a width is bigger, or if the hole is bigger, then baby may have holosystolic murmur. Holosystolic murmur, and which is called as a cardinal sign of ventricular septal defect also, which is present in the ventricular regurgitation also. So coming to the holosystolic murmur, before explaining that, if this is a diastole, then there is a sound called as lub. Then there is a systole. Then again there is a sound called as dub. Then there is a again diastole. So this is a normal pattern of heart sound. But in this particular holosystolic murmur, usually the murmur is at the lowest pitch here. But when it comes to the S1, suddenly its murmur increases, and again if it comes to the S2, again start decreasing. So you will hear a sound, very high sound at S1, immediately after S1, and as it comes to the S2, the sound starts reducing itself. So this is related to the holocystic murmur. Third, if at all the width are more than 2 and the width is bigger, then child may have arrhythmias. Then if at all there is no proper treatment, it can lead to increased or chronic increase in pulmonary blood flow, and that can lead to congestive heart failure. So these are the clinical features of ventricular septal defect. Diagnostic evaluation. Under diagnostic evaluation, the first thing is history collection, as you all know, and as I have discussed in atrial septal defect also, to know whether this particular disease condition is basically from parents or genetic or because of exposure to any radiation. Second one is physical examination. Under physical examination, that too under auscultation, we can see this hollow systolic murmur as I have discussed in the clinical feature. Third thing is X-ray. X-ray shows the heart's size and pulmonary flow patterns. Next one is Holter monitoring. Holter monitoring usually it exhibits the electrical activity of the heart throughout 24 days or throughout a day. Then MRI heart do suggest what is the defect, where is the defect, whether there are multiple defects or what, or whether it is a membranous or whether it's a like muscular. These all can be visualized through MRI heart. So these are related to the diagnostic evaluation. And last part we will discuss, that is related to the management. Under management particularly we will see non-surgical and surgical management. It is as same as atrial septal defect. Under atrial septal defect we will treat the upper part, and in ventricular septal defect we used to treat in lower part. In non-surgical, same cardiac catheterization is used. Which is inserted through either femoral or cardiac artery, and it is introduced within this, and where we can occlude this particular part through a ampetizer occluder, occluder, where the hole is occluded through a coil. It is called as coil occluder also. And second one, in case of surgical management, we will do a patch closure. We will do a patch closure. It is called as mainly Dacron patch. It is called as a Dacron patch, which is made of a photograph, as I told earlier. So in this particular condition, a patch is attached over this particular hole, and it is sutured by side, where it stops the blood which comes from the left side to right side. So left to right shunting is prevented by this particular method. So these are the non-surgical and surgical management of ventricular septal defect.